Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication. Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hi everyone, my name is Dr. Saihari Sadanandan. I'm the Director of Tampa Cardiovascular Interventions and Research. I'm an interventional cardiologist at 3 different hospitals in Tampa: St. Joseph's Main Hospital, St. Joseph's Hospital North, and Advent Health Carrollwood Hospital. I'm here to present my case using Aggrastat with a short infusion. The purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who may not be familiar with contemporary use of 2B3 inhibitors. Here are my disclosures. I received financial support from Medicure, the manufacturers of tirofiban, for creation of this video. Let's dive into the patient clinical presentation. Here is a 68-year-old male with history of hypertension, hyperlipidemia. He has chronic Parkinson's disease. He has no history of coronary artery disease with a prior history of bypass surgery many years ago. He was admitted with chest pain, non-ST segment elevation myocardial infarction, and a ventricular fibrillation cardiac arrest 3 weeks prior to the current admission. During that admission 3 weeks ago, an urgent cath had demonstrated a chronically occluded native RCA, severe diffuse stenosis of the LAD, and a chronic total occlusion of the mid-circumflex, which was a very large dominant vessel. All of his graphs, including Lima to LAD, SVG to OM, and SVG to RPDA, were occluded. Given his presentation with NSTE-ACS and a resuscitated cardiac arrest, he underwent successful revascularization of both his LAD with stenting as well as CTO revascularization of his left circumflex with overlapping biotronic stents, and he was discharged home. The RCA was a moderate-sized vessel, chronically occluded, and hence was not revascularized. The patient's pre-discharge LVEF was about 50%. He was readmitted to the hospital 6 days later after discharge with recurrence of chest pain, and the troponins were elevated to 10. His EKG demonstrated evidence of precordial ST segment depressions in leads V1 to V4, consistent with a posterior myocardial infarction. Upon questioning, the patient admitted that he had not filled his Plavix prescription due to inability to travel to pharmacy and was not taking dual antiplatelet therapy as prescribed. Given his presentation, a subacute stent thrombosis was strongly suspected. He was started on IV heparin and was taken for an urgent cardiac catheterization. His cardiac catheterization demonstrated that his right coronary artery remained occluded with a chronic total occlusion and was unchanged. The LAD stents were widely patent. However, his left circumflex, which was recently stented, was occluded in its distal portion at the level of the distal stent, consistent with a subacute stent thrombosis. He received heparin as IV anticoagulation during the procedure. His ACT was maintained about 250 seconds. And the plan was to proceed with treatment of the stent thrombosis of the distal left circumflex stent. Before we discuss our strategy, as a refresher, Aggrastat or tirofiban hydrochloride is a reversible antagonist of fibrinogen that binds to glycoprotein 2B3 receptor, where it blocks the final common pathway to platelet aggregation inhibition. It has a 2-hour half-life, and platelets return to normal function in about 4 to 8 hours after you stop infusing the medication. Aggrastat provides a very potent and rapid platelet inhibition and has a very consistent response across patient population. Importantly, through its mechanism of action, Aggrastat has the ability to disaggregate an existing thrombus, which neither an anticoagulant like heparin or a P2Y12 inhibitor can do. There are, however, limitations to what kind of thrombus it can disaggregate. It usually works best in fresh thrombus. So back to our case, here is how we decide to proceed. This was clearly a subacute stent thrombosis due to premature cessation of Plavix or lack of initiation or continuation of Plavix after discharge. So we decided to proceed with PCI. Using standard techniques, the stent thrombosis was crossed with a run-through wire. And daughtering of the lesion with the uninflated balloon, which is just advancing the uninflated balloon through the thrombus and back, did not result in an antegrade flow, suggesting a larger thrombus burden. So we decided to initially perform a penumbra mechanical aspiration thrombectomy using a CAT-RX catheter. However, because of the tortuosity and the previous stent in the mid and distal left circumflex, this catheter would repeatedly hit against the stent edge in the mid left circumflex and would not advance to the site of occlusion. Attempted thrombectomy performed from the catheter proximal to the occlusion did not establish antegrade flow. We decided at this point of time to use Aggrastat bolus and infusion and performed PTCA of this balloon with a PTCA of the lesion with a 2.5 millimeter balloon to establish antegrade TIMI3 flow. We then proceeded with IVUS of this occluded stent, and the intravascular ultrasound demonstrated a recoil of the previously placed stent and a significant thrombus burden distal to the stent in the distal left circumflex. The vessel measured 3.0 millimeters in the distal portion and 3.5 millimeters in the mid portion of the stent. So we decided to restent these lesions, and we stented them with a long 3.0 times 38 millimeter Medtronic Onyx stent and post-dilated the mid portion and the proximal portion with a 3.5 times 20 millimeter NC balloon at 18 atmospheres. Following post-dilatation, we performed a post-stent intravascular ultrasound to confirm a well-opposed and expanded stent. Final angiogram then demonstrated no residual stenosis, no dissection, complete resolution of thrombus, and TIMI3 flow in the left circumflex. The patient left the lab in a stable condition with no chest pain, improved ST changes, and Aggrastat was continued for 3 to 4 hours post-procedure. We only used a short infusion of Aggrastat because of the patient comorbidities, his fragility, increased bleeding risk, and the fact that we had established excellent results with prompt TIMI3 flow. Since the stent thrombosis happened with the initial prescription of Plavix, and given the complexity, we decided to change Plavix to Brilinta prior to discharge, and the patient was discharged home. So here are some of the takeaways from this case. Aggrastat can be used with a short infusion. The case exemplifies that there will be situations where a mechanical thrombectomy may not be feasible due to anatomical challenges in the setting of a thrombotically occluded vessel, in this instance, due to a subacute stent thrombosis of left circumflex. Prompt and early use of Aggrastat during PCI can help with intraprocedural pharmacological management of the thrombus to achieve successful results with no distal embolization and complete thrombus resolution. Aggrastat use in this case facilitated a successful PCI in a patient who had subacute stent thrombosis and required only a short infusion. Thank you for watching, and if you have any questions, please reach out to the Aggrastat team for more information.